Welcome back to Corium. I'm Brian Gilberti, and today we're joined by Dr. Ben Friedman. Dr. Friedman is a full professor in emergency medicine at Montefiore and a remarkable educator and researcher. He is extensively published in areas of headache and back pain, along with other topics under the umbrella of pain management in the ED. I have to say that among all the badges he wears, perhaps the most impressive is that he's been working nights in the Bronx for 22 years. Now, I've had the great fortune of working with him and learning from him, and when it came time to cover the topic of migraine on the show, Dr. Friedman was the first name that came to mind. So we're really excited to have you here on the show, and thanks for being here.
Thanks. It's a pleasure to be here.
Now, let's warm up for this episode with talking about the initial approach to diagnosing migraines. What are some of the hallmark symptoms you look for when a patient comes in with what's billed as a migraine? Is there anything in the history or exam that helps point you towards or away from that diagnosis?
So there's actually two interesting questions there. One is differentiating the primary headaches, that's migraine, tension-type headache cluster, from pathologic secondary causes of headache, brain tumor, subarachnoid hemorrhage, something like that. The other question is differentiating migraine from the other primary headache disorders. With regard to differentiating the primary headache disorders from the secondary headaches, there are some useful tools out there. The Ottawa subarachnoid hemorrhage rule is one that comes to mind. Patient history, though, is very important in understanding if this is truly a novel headache or if the patient has had a history of these similarly. What I found over the years is that the patient perspective on this headache versus the other headaches that the patient has had previously can be impacted just by being in the ED. The chaos of the emergency department and the pain that the patient's suffering sometimes makes that acute headache seem far worse than the others, and a little bit of perspective sometimes is useful. Here's a specific anecdote to illustrate what I mean. There have been a few times that I've gotten sign out when I come in for my shifts at 11 p.m. and the doctor signing out to me would be like, that patient over there has the worst headache of their life. I've ordered a CT scan. Please do an LP once that CT scan is done. And meanwhile, I've treated the patient with some metoclopramide. So when I finish sign out and go on my rounds and chat with the patient says, "Doc, I'm ready to go home." And I'm like, "Well, what about your CT scan?" And they're like, "No, the headache is fine." And I think sometimes after patients have been treated and feel a little bit better, they're often able to put the headache in better context with the headaches that they've had before. So I think one of the lessons for me is reevaluation after treatment is good for understanding the true severity of the headache in context with headaches the patients have had previously. With regard to differentiating migraine from the other primary headaches, many emergency physicians make the argument that it doesn't really matter because I'm going to treat them exactly the same. I think there's one case in which it does matter. So differentiating cluster from migraine is important. The thing about cluster headache is it, by definition, it lasts no more than 3 hours. So a patient will come with a cluster headache, and by the time they arrive in the ED and get registered and triaged, and you get around to seeing them, the headache has mostly resolved. And they're like, "I'm okay, doc. My headache's gone." And you're like, "Great, headache resolved." But the problem with cluster, as you know, is it's very likely to come back the next day and the day after that. And so failing to identify cluster, sets the patient up for suffering. And in fact, cluster is a very treatable disease. And so if you can identify the patients who are having cluster, you can do a whole bunch of good for that patient. With regard to differentiating migraine from tension-type headache, there's a little bit less urgency, I think, to do that. The one advantage of giving the patient a specific diagnosis, you have migraine, you have tension-type headache, is you're then giving them a tool that they can use to interact with other physicians and to research their disease online and help themselves understand the disease. But with regard to treating migraine versus tension-type headache, both of them respond to the NSAIDs. Both of them respond to the anti-dopaminergic medication. And in fact, some tension-type headache will even respond to sumatriptan. So I think there's less urgency to make that differentiation there in the ED. And interestingly, one of the defining features of migraine is that it's a functionally impairing headache. And so for the most part, the headaches that bring people to the ED tend to be migraine, even if they don't seem like a migraine. So even if the patient describes the headache as sort of pressure rather than throbbing, or bilateral rather than unilateral, if it is a functionally impairing headache, all the patient wants to do is curl up on a bed, odds are that it's probably migraine.
Okay, so let's say we have this patient that was initially undifferentiated, and we start crossing off the really bad things from the list and whittling down the diagnosis, and we're left with migraine. Now let's move on to treatment. What are some of the pillars of treatment that we know work for the treatment of migraine?
So the wonderful thing about migraine is there actually is a whole bunch of treatments that work well. And this is in contrast with the other syndrome that I study a lot, low back pain. So, both of these are recurrent pain disorders that can progress to chronic disease if not treated well, and in some patients. The problem with low back pain is we really don't have any good treatments for it. Beyond the NSAIDs, nothing works all that well for low back pain. I mean, we've done studies looking at skeletal muscle relaxants, at opioids. There really are very few medications that help low back pain. Migraine has a whole bunch of medications that are effective both for the acute treatment of migraine and also for migraine prevention. With regard to the acute treatment of migraine, fortunately, practice has evolved over the last 2 or 3 decades away from opioids. Opioids used to be used very commonly as first-line treatment in the ED. And nowadays, anti-dopaminergics are used in about 2/3 of all ED visits. And so the anti-dopaminergics are medications like metoclopramide or prochlorperazine, which is Compazine, or droperidol, which is actually very effective for migraine, and even actually haloperidol, another anti-dopaminergic, has great efficacy data for acute migraine. The parenteral NSAIDs are a reasonable choice for treating migraine. So ketorolac or ibuprofen, even IV acetaminophen is a reasonable choice. Another medication that I like using is dihydroergotamine. So IV dihydroergotamine or DHE is an old school medication that actually works really well. The big problem with dihydroergotamine is it causes a whole bunch of nausea, and so I'll combine DHE with an antiemetic like metoclopramide for even more efficacy. It's important to talk about the triptans, which have been FDA approved for migraine for a few decades at this point, but are very rarely used in the emergency department. And for some reason, emergency physicians have never really embraced the triptans. Part of the reason why is there's really only one parenteral triptan available, and that's subcutaneous sumatriptan. We've done studies looking at subcutaneous sumatriptan versus metoclopramide in the ED. And the problem with sumatriptan is, number one, it's not quite as efficacious as the anti-dopaminergics. We've done studies showing that, and a few other people have done that as well. But also sumatriptan causes a whole bunch of side effects. So palpitations, flushing, chest pain. The number needed to harm for subcutaneous sumatriptan is 4. Most of these are sort of nuisance side effects, unpleasant rather than dangerous. But in these patients, sometimes you'll give them sumatriptan and you make the headache worse, and that's the last thing that these patients want. And so for these reasons, the triptans have never really caught on in the emergency department. That being said, for patients who can tolerate oral medication, sitting the patient in a chair and giving them an oral triptan, so that was something like 100 milligrams of oral sumatriptan or elatriptan or naratriptan. There's a whole bunch of them, and that's actually reasonable treatment for many patients, and may be appropriate given how busy the ED is and what the patient's needs are. One type of treatment that's worth discussing is a treatment that's emerged, over the last few decades, but been playing more of a role over the last 5 years or so in the emergency departments, and that's the nerve blocks. So there's two types of nerve blocks that I want to talk about. One is the greater occipital nerve block, and the other, ganglion block rather than nerve block, is a sphenopalatine ganglion block. It's difficult to demonstrate here on this audio podcast, but the greater occipital nerve block is fairly easily performed using landmarks identifiable on the back of the patient's head, using the occipital notch and the mastoid. One can identify the greater occipital nerve and put some lidocaine or bupivacaine adjacent to the nerve, and that actually is quite effective in the acute setting. The sphenopalatine ganglion block is performed by dribbling a local anesthetic up a patient's nose, trying to target the sphenopalatine ganglion in the back of the middle turbinate. Also, a fairly effective treatment for ED patients. The nice thing about the nerve blocks is you are targeting the nerve specifically, and so you thereby avoid any systemic side effects. So these are patients that you could sort of sit in a chair, do the procedure. Sphenopalatine ganglion block, you'll have to have them lie down to do it, but you do the block. 15 minutes later, they're ready to go back to work without any medication side effects, without any of the akathisia that you see with anti-dopaminergics or drowsiness that these medications often cause. So these are emerging as a great treatment.
Okay, very interesting. And I know that your paper on nerve blocks requires some additional layers of understanding when we're interpreting the results. So, can you talk to us about how we should interpret these results with a keen eye?
So we did a study comparing greater occipital nerve block to metoclopramide. This was a randomized double dummy design. So patients who got real metoclopramide got a fake nerve block, and patients who got a real nerve block got fake metoclopramide. And the results of the study were disappointing. Metoclopramide outperformed the greater occipital nerve block in this randomized study. But among the population of patients who had the nerve block performed by an experienced practitioner, that is a practitioner who had done the nerve block at least 6 or 7 times previously, these patients actually had better outcomes than the patients given metoclopramide. And so I think this nerve block is increasingly going to have a role for treating patients in the emergency department.
Great, Dr. Friedman. You've covered many of the medications we typically use in these situations, but I noticed that some of the common components of migraine cocktails, specifically Benadryl and fluids, weren't mentioned. So could you discuss the role or lack thereof of these medications in the ED management of migraines?
So Benadryl or diphenhydramine historically was used for 2 reasons. One was efficacy and the other was preventing side effects. A big side effect that we see when administering the anti-dopaminergics is akathisia, which is very distressing to the patients. I'm sure many of you have seen akathisia after giving the anti-dopaminergics. You have a patient who's curled up in a ball because of their migraine. You give the anti-dopaminergic, and all of a sudden the patient is jumping out of the stretcher, pulling out their IV, and saying they have to go home. It's a very distressing experience for the patients, and best to try to avoid it. We did a randomized study looking at, it was essentially a placebo-controlled study. Patients were randomized to metoclopramide plus diphenhydramine or metoclopramide plus placebo. And we found no difference at all in any outcome in that study. So there was no difference in efficacy. There was no difference in the rate of akathisia. There was no difference in the rate of drowsiness. And even within the subgroup of patients who were experiencing allergic type symptoms, so runny eyes, runny nose, even in that subgroup, diphenhydramine didn't outperform placebo among the patients who got metoclopramide. So I do not think that diphenhydramine has a role as sort of a routine part of a migraine cocktail. With regard to IV fluids, there really has been no compelling data showing IV fluids are of benefit for patients with acute migraine. The data isn't so high quality, but I don't think there's any reason to administer it routinely unless you have clinical evidence that your patient is dehydrated from the nausea and vomiting that often accompany migraine.
Okay, so Benadryl and fluids likely won't do much to help our patients' migraines. What about magnesium?
So many people like to talk about IV magnesium for treatment of migraine in the ED. There actually have been a whole bunch of studies on IV magnesium, and the results are very conflicting. Some of the studies show benefit, but a lot of the studies don't show benefit. And in fact, there's even one study that showed harm. Patients who got magnesium had worse pain outcomes. So for the most part, I do not use IV magnesium for treatment of migraine in the ED.
Okay, so magnesium may not have a strong foundation in the literature for treating migraines. That's clear. Now, when we approach a patient with a suspected migraine, we typically start with our first-line agents and hope for the best. And most of the time, patients feel much better and we can discharge them. But what if they don't improve? Can you walk us through your approach to managing headaches that are refractory to our initial first-line medications?
Yeah, so for my first line treatment of migraine is metoclopramide, and I combine that with dexamethasone. Hopefully we'll talk about that more a little bit later, but dexamethasone will prevent the recurrence of headache. So I give metoclopramide 10 milligrams plus dexamethasone 4 milligrams IV. If instead of metoclopramide you wanted to use prochlorperazine, which is Compazine, or droperidol, that's certainly very reasonable. If the patient doesn't improve after that first dose, I will then give another dose of metoclopramide, this time with an NSAID. Usually for me, that's ketorolac. So I'll give another dose of metoclopramide, 10 milligrams, plus ketorolac, 15 milligrams IV. If that doesn't work, I'll give a third dose of metoclopramide, this time along with dihydroergotamine, DHE. That's 1 milligram of IV DHE. Before giving these successive rounds of treatment, I will offer the patient the nerve block. And if the patient wants the nerve block before the initial treatment or after my first round of treatment, I'm happy to do it at any time. The results are often quite good with the nerve blocks. If we haven't successfully treated the patient's migraine after 3 or 4 rounds of treatment, at this point, I'll reach for opioids. I think it's a bit cruel to withhold opioids on principle when none of the other treatments are working. But I would save the opioids for farther down on the treatment protocols. If you call the neurologist, they'll often recommend one of the anti-epileptic or anti-seizure medications. Valproate has been studied fairly extensively, and really the data is far from compelling. I do like propofol. Sometimes I'll give low-dose propofol, maybe 20 milligrams IV. Sometimes that helps out with migraine. There's a little bit of data supporting the efficacy. Ketamine has been studied and really does not look all that good for acute migraine. Two other treatments that are worth mentioning are relatively novel treatments. One is called lasmiditan. It's a 5-HT1F agonist, so similar to the triptans in targeting serotonin. But because it only targets the 1F subtype of the receptor, it doesn't have a lot of the vasoconstrictive properties that the triptans have. So lasmiditan is a fairly effective medication. Unfortunately, a whole bunch of side effects with it. This is a medication that you could use as a third, fourth, or fifth line medication if you need something to treat the patient. Also, there's a whole new class of medications called the CGRP antagonists. So we know that CGRP is an important molecule in migraine pathophysiology. There are a few FDA-approved CGRP antagonists that have not great number needed to treat, but are fairly well tolerated. And so these medications too might play a role once you have a patient who isn't getting better with dihydroergotamine or ketorolac or whatever other medication you're using for acute treatment.
Now, that covers the treatment for migraines. Let's say the patient feels better and is ready for discharge. What additional steps can we take at this point? Are there any medications we can prescribe or advice we can offer to help prevent them from returning to the emergency department or experiencing a recurrence of their headaches?
So a big unrecognized problem is the very frequent recurrence of headache after ED discharge. So we know that among patients who are successfully treated, these are patients who are like, "Doc, I feel great. I want to go home." 50% of them will have a functionally impairing headache within 48 hours of ED discharge. And over the week after ED discharge, the median number of headache days that people report is 3. So, more than 50% of your patients will have 3 days with headache. A bunch of your patients will have even more than 3 days with headache. So what can you do? So the steroids are a very useful treatment for preventing headache recurrence. The number on dexamethasone, if you give dexamethasone initially, a number needed to treat to prevent headache recurrence is around 9 or 10. I don't have great information about the best way to dose the steroids. So it very well may be that a short burst of prednisone is as good as IV dexamethasone. Maybe these patients need a prednisone taper. We did a randomized study looking at dose of dexamethasone to administer in the ED. And patients who got 16 milligrams of IV dexamethasone did no better than patients who got 4 milligrams of IV dexamethasone. And that's why I stick with the dose of 4 milligrams of IV dexamethasone for these patients. But beyond giving the steroid, I think it's also important to give the patient some medication to treat the headache when it recurs. And so this is a prescription. You could give a prescription for an NSAID like naproxen. Also, the triptans are very good in this role. And in fact, patients can combine a triptan with an NSAID for even better efficacy. One other under-recognized problem is chronic migraine. So chronic migraine is very common in the American population. If the overall prevalence of migraine is about 12% of the U.S. population, about 1 to 2% of the U.S. population has chronic migraine. Chronic migraine is defined as headache on more days than not. So these unfortunate patients have headache more than 15 days per month. Now, for the most part, this is an outpatient problem. And if you could hook the patient up with a neurologist or a headache specialist, you'll be doing a world of good for these patients. But for your patients who can't access timely outpatient care, there are a whole bunch of medications that are effective for migraine prevention. For emergency physicians, probably the easiest one to prescribe is propranolol, which is an evidence-based treatment for preventing headache days over the months after somebody's first diagnosed. Anti-epileptics have a role here in migraine prevention. Botox is useful for migraine prevention, and there's a whole new class of monoclonal antibodies targeting CGRP for preventing headaches among patients with migraine.
Okay, Dr. Friedman, we've covered a lot today. Let's cement it with some take-home points. One of our key tasks when a patient presents with a possible migraine is to distinguish between a primary headache, like a migraine or tension type or cluster headache, and secondary causes, like a subarachnoid hemorrhage. use patient history, and reevaluate after initial treatment, as symptom improvement can clarify the diagnosis and reduce unnecessary imaging or procedures. Effective acute migraine treatments include anti-dopaminergic medications like Reglan or Compazine or Toradol, and parenteral NSAIDs like Toradol. Reserve opioids for refractory cases and be cautious with triptans in the ED due to their side effects and their lesser efficacy compared to anti-dopaminergics. Though used often, studies show that diphenhydramine does not prevent akathisia from anti-dopaminergics nor improve migraine outcomes. Also, the use of IV fluids does not have a substantiated role unless there's evidence of dehydration. Leaving out these two treatments, which have seeped into our treatment regimens, can streamline care and avoid unnecessary interventions. Next, greater occipital nerve blocks and sphenopalatine ganglion blocks are effective for migraines unresponsive to initial treatments. These procedures can provide relief without systemic side effects and can be a valuable tool in the ED for difficult cases. Now, finally, preventing recurrence of migraine is also one of our goals here. For this, a single dose of dexamethasone at 4 milligrams IV can reduce the risk of headache recurrence after discharge. You can prescribe NSAIDs or consider triptans upon discharge to manage potential recurrences, and consider preventive therapies like propranolol for patients with frequent migraines. Okay, that'll do it for this episode. Dr. Friedman, thanks for being on the podcast.
It's been a pleasure to be here. Thanks very much for inviting me.